Hello and very warm welcome for this Delta videos or recent updates in community medicine. We all know that human population, we as humans have been ever evolving since time and ages. And so is the human sciences or the medical sciences or the population sciences. Unfortunately, whatever it is, probably the community medicine subject or the PSM subject has been always very dynamically changing, and it's important for you to have always a catch up for these community medicine lectures. So now let us pick up the first vital statistics, that is the changes or updates in SRS bulletin from the Government of India. Beta, please note that SRS bulletin was released in October 2021. This is the reference year is 2019. So the salient features in SRS data that you need to remember is that infant mortality rate that has been updated in October 2021 to 30. The crude birth rate is now 19.7 and the crude death rate is 6. So roughly you can say 26 and 30 is what is easy numbers for you to remember. If you are a nerdy kind of person who's like more into data, who wants more always, so please, you're most welcome to do that. Please note that the highest birth rate for year, the data as per the SRS 2021 has been recorded. Highest birth rate has been recorded for the state of Bihar, followed by Uttar Pradesh and Madhya Pradesh. The death rate has been highest in Chhattisgarh, followed by Madhya Pradesh and Kerala. Natural growth rate is technically highest for Bihar because the crude birth rate was also highest for Bihar, and the infant mortality rate is unfortunately higher or highest, we can say, for Madhya Pradesh, followed by Uttar Pradesh, followed by Assam and Chhattisgarh. So these are some important numbers you would like to remember. Coming to the NHS5 data, NHS5 was again released in September-October in year 2021. This NHS5, number 5, you have to memorize this number. NHS5 was based on 2019 and 2020 survey. MCQ number 1, this NFHS data is conducted by the Ministry of Health and Family Welfare, but it had been outsourced to the International Institute for Population Sciences, that is the IIPS, which is in Mumbai, Maharashtra. So this IIPS was technically responsible for conducting the NFHS5 survey in India. A few salient features of the NFHS5 survey that you need to memorize is that NFHS5 was taking into account some of the new topics were taken into account, like preschool education, disability, access to the toilet facility, death registration, bathing practices during menstruation, or the hygiene for a female during menstrual cycles, and methods and reasons for abortions. And for the first time, blood pressure and the blood glucose were also taken in the NFHS5 data, along with waist and hip circumferences, but the HIV testing had been dropped this time in NFHS5. There were 4 different questionnaires. These are called as the schedules. So we had 4 schedules, one schedule for the male, second for the female, and then we had 2 separate schedules, one for the biomedical markers or the biomarkers and the household schedule. So there were 4 schedules you need to memorize. Salient data numbers, if you would like to remember, you don't need to remember each one of these, but yes, you should remember most of them. Literacy rate, for example, is important for you to remember as 84.5 for males and 71.5 for females. You should also remember the sex ratio is 1020 for general population. So you have 1,020 females for every 1,000 males, which is an important landmark history, milestone history in the public health system of India. That sex ratio is now higher than 1,000 for females is to males. You can also remember, this is again a very big welcome news, that the TFR, that is the total fertility rate, is now as 2. Another important point that you would like to remember is that the total number of females taking the IFA tablets in India is only 45%. In India, the total number of percentage of females who were taking IFA tablets for at least 100 years, which is not a very good news. You should also remember that you can see that the stunting or the wasting or underweight for age. The stunting is 35, the wasting is 19.3, the underweight is 32. You can technically say that 1/3 of the children in India, they are undernourished either because of stunting or wasting or underweight for age. Overweight is a major issue, especially in females and in males, like both. So you can remember that roughly approximately 1/4 to 1/5 population of the Indian population is actually overweight, and 1/3 of the children are actually wasted or stunted, or they are underweight for age, right? Next important line you should somehow memorize is that the diabetic prevalence in either males or females is roughly around 13 to 15%, and the hypertension prevalence in males and females is roughly around 20 to 25%. So again, 1/4 to 1/5 population is actually hypertensive in India. Total dependency ratio has been revised for India, so it is now 48.74 instead of a 52 dependency ratio. So now the dependencies have actually decreased, and that's what it means, that we have a demographic gift or we have a demographic bonus. So some of the salient statistics you would like to remember, apart from these one that we have already discussed for your exam, you should remember the MMR, IMR. So the maternal mortality ratio, it's a MMR. R would stand for a maternal mortality ratio. The formula is maternal deaths divided by the live birth. So please note that MMR, that is maternal mortality ratio, is different from maternal mortality rate. In ratio, the numerator is different, the denominator is different. That's what you know. So in ratio, you already know that the numerator and denominator, they are different. And that's the reason the formula for maternal mortality ratio, it is number of maternal deaths by live birth. So maternal deaths is different and live birth is different population. So that's why we call this as the ratio. If somebody asks you about the maternal mortality rate, it will be number of maternal deaths divided by something from which the maternal deaths are happening. So answer to this is the total number of females in the WRA, that is the reproductive age group. So the multiplicative factor that we use in maternal mortality ratio is per lakh live births. So it is, please note, it is 113. So this is according to the latest bulletin, the special MMR bulletin that we already have, that was released in year 2019-20, and it was based on the 2016-18 report. Then the infant mortality rate, please note, is 30. Just now we discussed as per the NFHS data. The neonatal mortalities or the under 5 mortality, this is according to the Registrar General Statistical Report, again based on 2018 data. So the neonatal mortality and the under 5 mortality is 23 and 36. The crude birth rate and the crude death rate, just now as per the NFHS data we have discussed, it is 6 and 19.7. So these are the vital statistics, salient vital statistics that you should be remembering for your exam. Coming up next is the National TB Elimination Program, and there are a lot of updates and new things for you to memorize or remember for National TB Elimination Program. There are around 10-11 changes. So what you can do is, you already have the Marrow edition 5 module with you, the video module. So if you have watched all the video modules, you first need to watch the video modules, and then only you should be watching this Delta update. I'm not going to teach you the whole TB elimination program right now. I will be just doing icing over the cake. So there is some icing which is now updated to the new icing. So I will be telling you that this has changed and remaining everything is still the same. So for that reason, you should first watch the baseline or the foundation things. First line first, the first is the National Strategic Plan. This is the NSP for India, and what are the targets. Please note that the National Strategic Plan was devised in year 2017 till 2025. Under this plan, we want to end TB by year 2025. The Government of India, the National TB Elimination Program, wants to end TB. That's the target, to end TB by year 2025. So by year 2025, we want to end TB. In this, what are the chief targets? Introduction of TrueNat. Please note that TrueNat has to be started in India. TrueNat is a Indian-made investigation or a special test to diagnose tuberculosis. So it is a very rapidly occurring. So TrueNat will tell you the presence of the Mycobacterium tuberculosis within 1 hour, and the presence of resistance within another 1 hour. So in total 2 hours, it is going to tell you the presence of plus or minus of TB and plus and minus of the resistant strains. So, and it is Indian built. So under this NTB strategy by year 2025, TrueNat has to be introduced in all the places in India. Second is, there has to be nationwide distribution of the UDST, that is Universal Drug and Sensitivity Testing, along with launch of Delaminid and bedaquiline at all the levels in India. So that is the target of the NTB 2025. So please note, launch of TrueNAT with bedaquiline and delaminid as MDR-TB regime across pan-India. So that is what we need to achieve by year 2025. Point number 2, coming over to the diagnostics in TB. We already know that sputum and chest X-ray, they form the basis of diagnosis of TB, right? So sputum is highly sensitive and specific for tuberculosis. Apart from the sputum and chest X-ray, you also must have heard about the CBNAT. CBNAT is the expert TB, expert mycobacterium TB. It tells you about the TB presence and the rifampicin. I think we all know. Now coming is the 3-star or 5-star MCQ. This can be asked in your exam. We want to launch TrueNAT. So TrueNAT is from it's a real-time quantitative micro PSR system. It was developed by the Marrow Diagnostics, which is in Goa, in Maharashtra, India. So this Marrow Diagnostics, they launched this TrueNAT, and TrueNAT is a wonderful investigation which is going to tell you about the TB and the resistant strains both. So this is an important update for you. Next is you must have heard about the line probe assays and the DSTs. Many students get confusion over here, so I'll take this opportunity of giving you the catch-up module in the Delta module and also solve some of the controversies right now. See, line probe assay. What is line probe assay? Line probe assay, please note that beta, it is a molecular test. It is a molecular based test, whereas the DST, that is drug and sensitivity testing, it is a phenotypic test which is a culture based. So usually we use culture, the liquid culture or the solid culture. So the drug sensitivity testing is a culture based, whereas a line probe assay is a molecular based. The technology or the technique of doing this test is entirely different. So the line probe assay, in the line probe assay, we might have two types of line probe assays. We might have a FLLPA or SLLPA, first line probe assay, first line drugs, or we can have the second line probe assays. The first line is going to test for the RPO gene R resistance and the CATG gene and the INHA gene resistance for isoniazid and also for ethionamide. The second line LPA will test for the fluoroquinolone resistance. What are the genes for fluoroquinolone? This has been asked in your AIMS exam in just maybe last year or last to last year, the GYRE A and the GYRE B. The RRS and the EIS, these are for kanamycin, low-level kanamycin resistance for the second line injectable drug resistance. So the first line will test basically for H resistance, and also it can test for the R resistance. The second line will technically test for the kanamycin or the fluoroquinolone or the second line injectable and the fluoroquinolone resistance. Now comes the drug and sensitivity testing. The DST is done via a technique called as BACTEC method and BACTEC MJIT 960 method. So this is a BACTEC MJIT 960 method. It is an automated liquid culture system which has been approved for conducting the drug sensitivity testing in India. I also know that there is a LJ media, which is a solid media, but it is usually not done and not done for diagnosis, at least in India. So coming further, more to talk about the LJ media, there is something called as a TAT time. TAT stands for the turnaround time. So what is the turnaround time, laboratory turnaround time that may be asked in your exam? It's not an update, it's just an extra information for you to know. The LJ media, that is the solid culture, the Lowenstein-Jensen media, usually takes 4 to 8 weeks for a sputum negative and 3 weeks for sputum positive. So therefore, the inoculation of the sample for DST is also done on LJ media as a backup plan, that in case there is some contamination on the liquid media, at least you have the solid media. So solid media, the utility under the program is only for as a backup plan. It is not approved for doing diagnostics in India. Why? Because it's so much time taking. For diagnostic, either we use the automated liquid culture, that is the BACTEC method, or we have the molecular testing, or we have the rapid identification. Rapid identification is not again done for diagnostics in India. It is only to check for the latent TB or the presence of the TB bacilli in humans. So it is not used for diagnosis. For diagnosis, technically we have only the molecular testing or the liquid culture. So the liquid culture is not for diagnosis. Actually, the liquid culture it's one of the important mainstay. It's the gold standard liquid culture, that is the Bactec MJIT media method. But the liquid culture is universally used for drug sensitivity testing. Coming to the molecular test, you have the CBNAT. You already know that the turnaround time for CBNAT is how much? It is 2 hours. Turnaround time for CBNAT is 2 hours. Will you remember this? Coming next, there is also something called as TrueNAT. Please remember this. This beta can be asked in your exam. It is a lot of work is being done on TrueNAT, and it's a word of caution that probably if you're seeing this video before the exams are going to happen, TrueNAT is one thing that you cannot afford to miss beta. So please remember, you have to remember TrueNAT. TrueNAT is made from Mall Bio Diagnostics from Goa. And TrueNAT is a molecular test. It is a cheaper version of the CBNAT. It tells you TB detection within 1 hour and another 1 hour for presence of the resistance detection. So please note, TrueNAT is important. And then you have the LPA line probe assay for detection of drug resistance. It takes usually average 2 to 3 days. It can be as early as 1 day or as long as 3 days. So the automated liquid culture, this has been asked in your exam. This is again a 3-star MCQ. The liquid culture takes around 2 weeks, 1 week to 2 weeks for a sputum positive sample, 8 to 10 days to 12 days for sputum positive, and 2 to 6 weeks for sputum negative. So I just told about 2 weeks. So please correct that. It is 8 to 10 days for sputum positive sample and 2 to 6 weeks for sputum negative sample. So point number 3. So that is you have done 2 updates till now. One update was regarding the National Strategic Plan, the targets. Beta, the second update is regarding the diagnostics in TB. Coming to the third update. The third update that you need to remember is regarding the definition, some of the definition changes in MDR, XDR or pre-XDR. You already know, beta, what is MDR? What is MDR? You already know that MDR is nothing but H and R resistance both. It means both isoniazid and rifampicin resistance, right? What do you mean by XDR? It means H and R resistance. Resistance to both isoniazid and rifampicin plus resistance to any fluoroquinolone plus any second line injectable. That's what we already know, right? That's what we already know. So now there is a definition update, beta. You need to just upgrade your knowledge. Nothing very big. It's not some major change. You just need to remember it's not any second line injectable. So now it is any group A drug. So any resistance to isoniazid and rifampicin plus fluoroquinolone plus any second line injectable, instead of second line injectable, any group A drugs. What are the drugs in group A? So you have 3 categories of drugs. You have group A, group B and group C. Group A drugs are the main drugs which include 3 medicines, that is levofloxacin or moxi with bedaquiline or linezolid. Then you have adding additional medicines, that is clofazimine, cycloserine or terazidone. And group C is to some people or to some individuals who might not be able to give group A or group B. In those cases, we are going to use the backup, that is group C. Group C would include ethambutol, delaminid, pyrazinamide and so on. You have a lot of drugs in group C. So what is MDR? MDR is isoniazid and rifampicin. What is XDR? It is isoniazid, rifampicin plus fluoroquinolone plus any group A drug. And now there is another term that is called as a pre-XDR. What do you mean by a pre-XDR? It is nothing, that is H and R resistance plus any fluoroquinolone. So there might be some individuals who have fluoroquinolone resistance. That's important for the program to know. So now we have labeled those persons as a person who's called as pre-XDR. So that's a new definition for you. Next we come over to is the 4th point, that is a small change in what do you mean by a presumptive MDR. See beta, you already know that there is something called as defaulter in TB. So who is a defaulter? The definition has changed. The definition is same, the name has changed. So defaulter, instead of calling that person as a defaulter in TB, we now call that person as loss to follow-up. So that person is called as lost to follow-up. What is a person who's lost to follow-up? Is a person who has taken ATT, that is anti-tubercular therapy, for more than 4 weeks. That is taking ATT for more than 1 month, and the patient is already lost to follow-up. What do you mean by lost to follow-up? That is the patient who did not report back to the DOTS provider or who did not take medicines for more than 2 weeks. So in case there is a person who is taken for more than 4 weeks and left for more than 2 weeks, that is called as lost to follow-up, and the patient is microbiologically confirmed TB, that is taken under the presumptive TB. Then you also know there is something called as a relapse TB. So earlier we had a defaulter TB. Instead of defaulter, we call that defaulter as a loss to follow-up. Now there is a person, we used to call that as relapse TB. Now the relapse TB is now called as a recurrent TB. We have a recurrent TB, recurrent tuberculosis case. So what do you mean by a recurrent tuberculosis case? There is a person who was declared as cured after ATT and now is microbiologically confirmed again. That is called as a relapse TB, and it is technically called as a recurrent TB. Next is no response, or there is a poor response to the first line therapy. So that is failure in TB treatment. And important is contacts of MDR TB patients or children living with HIV with a history of TB death in household. All these are taken under the presumptive MDR. But there is a word of caution for use in presumptive MDR, that now we are almost universally doing a CB-NAT. That is called as a universal CB-NAT, or we are doing a universal drug sensitivity testing. We are already doing that, right? So let us say that this patient got symptoms of TB and you do a CB-NAT and then you find rifampicin resistance. So technically any such case is generally taken as a presumptive MDR, and we are already doing CB-NAT. So maybe this definition may get liquefied. There is nothing called as presumptive MDR. Either there are people with the TB, or there are the drug sensitive TB, or there are people with drug resistant TB. So very soon you'll understand more, but please note that in presumptive MDR case, there is inclusion of defaulters, that is now called as loss to follow-up. There is inclusion of recurrent TB or the relapse TB. There is also inclusion of failures, and there is also inclusion now of any contacts of MDR or children living with HIV or with history of TB death in the household. That is also a presumptive MDR case. Please note that. Coming to the next is a major change. This is again a 3-star to 5-star MCQ point for you. There is again a major change in the integrated TB management module for the multi-drug resistant or the extensively drug resistant tuberculosis, or easily we call these as DRTB management guidelines. So there is a major change in the DRTB guidelines. Let's see what the change is. In this case, I don't know if you can see the screen right now. In this case, you already know there are all TB patients are there. Plus there are people who are non-responders or failures or MDR cases or presumptive MDR. There are key populations which might have TB. So to all cases, you do CB-NAT. One thing is very major change, that is universal CB-NAT. Every case who is coming to a TB hospital, we do sputum and X-ray and we start the treatment. But along with the treatment, we also have to do a CB-NAT report has to be generated for all the cases of tuberculosis. That means every TB case who's yet to be put on treatment or who's already put on treatment, they have to get a CB-NAT done. So that's a very big important 3-star point for you. So that is called as universal DST, and that's what the target was under the NSP 2017 till 2025. So now we want that all the TB cases should get a universal CB-NAT done. Based on the CB-NAT, there might be people who are tuberculosis detected or tuberculosis not detected. I'm not talking of the people who are non-tuberculosis detected. So leave that aside. We are talking of the integrated DRTB management where all TB cases are there. So once you have a TB case, what will be this report of CB-NAT beta? The report of CB-NAT will either be a rifampicin sensitive case or it will be a rifampicin resistant case. Are you getting it? So once the CBNAT is done, either the patients will be rifampicin sensitive or they are rifampicin resistant. Let's talk about rifampicin sensitive first. That's easy to understand. Talking about the rifampicin sensitivity, you directly start them on what? You directly start them on drug sensitive TB regime. So there was a question in your Marrow Q bank. There was a lot of controversy on that a patient comes who's diagnosed with TB and sputum positive. What are you going to do first? Do CBNAT or start the patient on treatment? That is common sense. Please start the patient on treatment and do a CBNAT also. So there are some questions which lose their relevance with time. So in earlier times, CBNAT was not yet established in India. So the best answer was do ATT. Give the patient ATT, anti-tubercular therapy. But now CBNAT is important. So we start the patient on ATT and we do CBNAT. Done. So you start the patient on drug-sensitive TB regime. I'll talk about the regimes very soon. We're going to give the TB regime, drug-sensitive TB regime, and also do a CBNAT. So, and also do a first-line LPA. So please note to these cases, that's an important update for you. So wherever there is update, I'm marking a star mark. So we do a first-line LPA. In case there is no resistance detected on the first-line LPA. So what is the profile of this patient? This patient is rifampicin sensitive and there is no resistance of first line. So it is isoniazid sensitive. So to this patient, we will continue the DSTB. Common sense. In case there is isoniazid resistance. So now what is the profile of this patient? This patient is rifampicin sensitive but isoniazid resistant. So to these cases, we are going to do something called as a reflex testing. This is called as a reflex testing. Again, an important update for you. So the reflex testing has to be done for the second line LPA drugs, and we also do a DST, liquid culture sample. So for all the fluoroquinolones, the pyrazinamide, the linezolid and clofazimine. So you do reflex testing. This is called as a reflex testing LPA, the second line probe assay. Are we good with this? So you have patient, what's the profile of this patient who's going to get a reflex testing SLLPA done? That is isoniazid resistant and rifampicin sensitive. So based on the results of this reflex testing, if there is no other resistance, that means this patient is only isoniazid resistance. Now to this case, we are going to give H monopolydrug regime. So now you have learnt about two regimes. First regime is the DSTB regime. Second is the H monopolydrug regime. In case on rifampicin, in case on the second line reflex testing LPA, you get any resistance. So based on that, you're going to modify the regime and give to the patient. Are we done? Coming to the other arm. You remember the other arm? So first we had a rifampicin sensitive people, and now I'm going to talk about the rifampicin resistant. So talking about the rifampicin resistance, I'm going a little bit in detail. I'll show you in a zoomed mode that what is the rifampicin resistant. So in case the patient is rifampicin resistance detected, please listen carefully. To these cases, we will technically do first line LPA. This is again an important update for you. We will do a first line LPA and we will also do a second line LPA. We will also do a backup liquid culture DST. So we do all the three things. The first line, you should see the isoniazid status. You should also see the second line LPA, and you should also do a liquid culture. The second line, the liquid culture DST for pyrazinamide, for bedaquiline, for clofazimine, moxiflox, linezolid, delaminid. You don't need to memorize these names, the drug names. Just remember, we need to do FLLPA, SLLPA, and we need to do the liquid culture DST. Are we good till now? Now comes the update for you. Now the update is that in case there is no other resistance detected, mind it. In case there is, please note it. I'll write it down somewhere for you. Please note that I'll write it in different color. Please note if there is no other resistance detected. No resistance from this first line LPA or the second line LPA. Or if, mind it, very carefully listen, or if there is only isoniazid resistance detected. Isoniazid resistance, what is the cause of isoniazid resistance? Most common cause, you have INHA promoter gene mutations or you have the CATG gene mutations, right? So in case there is isoniazid resistance with either, I'm saying the word either. In case there is isoniazid resistance either with CATG gene or with the INHA, but not both. So in case, listen carefully, in case there is no other resistance, or in case there is only single gene resistance with isoniazid, in those cases we are going to start this new regime that is launched in this NTEP module this year 2021, June 2021. This regime is a new update regime, 3-star, 7-star, 10-star MCQ for you. This is called as shorter oral bedaquiline containing MDR RRTB regime. So what's it called? Shorter oral. Earlier it was injectable. You remember kanamycin, chopzi, I don't know if you remember it. But anyways, earlier I told you it's a shorter MDR regime. It's now called as shorter oral bedaquiline containing regime. So it has been shifted from injectable shorter regime to oral shorter regime. This is your update from June 2021. I have discussed most of the updates on social media. I've also discussed many updates in your revision videos, but this update is fairly latest and I could not get a chance to discuss with you. So please note that the shorter oral bedaquiline containing regime was launched in June 2021, and it has been incorporated for which patients? For the patients who have no resistance, isoniazid resistance, only either CATG or INH-A mutation. That is only rifampicin resistant patients and no isoniazid, or rifampicin with only single gene isoniazid. In those cases, we are going to give this new regime, shorter oral bedaquiline. In case there is isoniazid with both the resistance, or in case there is any fluoroquinolone resistance, then we need to give the traditional or the conventional all oral longer MDR regime. In case there are multiple, so you optimize the drugs schedule accordingly. So what you have learned over here, you remember you have learned about the drug sensitive TB regime. You have learned about the drug sensitive TB regime. You learned about the H-mono polydrug regime. You also learned about the shorter bedaquiline containing regime, and you also learned about the longer oral bedaquiline MDR XDR regime. Are we good with this? So this is what is the integrated module which looks like. So you have the drug sensitive TB regime. You have the H-mono polydrug regime. You have the longer oral MDR XDR regime. You have the shorter oral MDR XDR regime. And then you have always the optimized regime where you change the regime. So I'm going to talk to you about 4 regimes now. So what are those 4 regimes for you? The 4 regimes that you need to remember for your exam, the 4 regimes are either we can have a drug sensitive TB or we can have a drug resistant TB. So the drug sensitive TB, DSTB first line regime, the drug sensitive TB regime is still the same. It is previous regime only. It's the same regime, 2 months of daily HRZE and 4 months of daily HR and E. So please note, drug sensitive TB is 2 months of daily HRZE and 4 months of daily HR and E. The drug resistant TB regime could be H-mono polydrug regime, which is still the same. It is still the same, the 6-0 regime. 6-0, Z stands for pyrazinamide, E stands for ethambutol, R stands for rifampicin, O stands for levofloxacin. I know it might sound funny. O stands for ofloxacin. I technically mark O as any fluoroquinolone. So O will stand for levofloxacin. And now you have this newer shorter MDR regime. This is a new regime. This is the update for you. The newer shorter MDR regime. This is CHOB-Z regime. So you can mark it as CHOB-ZEE. CHOB-Z regime. C stands for clofazimine. H stands for high dose isoniazid. O stands for, earlier it was moxiflox, but now it is keeping simple, levoflox. B stands for bedaquiline. Z stands for pyrazinamide. E stands for ethambutol. E stands for ethionamide. So you are going to give 4 to 6 months of CHOB-Z regime and 5 months of CO-Z regime. CO-Z. C stands for clofazimine. O stands for levofloxacin. Z stands for pyrazinamide. E stands for ethambutol. And then you have the longer MDR regime, which is, please note, there is no intensive phase, no continuation phase. It's the same regime since the earlier Marrow edition 5 module videos. So the earlier regime, you must be remembering, no intensive phase, no continuation phase. we only have all oral longer MDR regime for 18 to 20 months. That is 2 L's, 2 C's and 1 B. So you have 2 L's, that is linezolid and levofloxacin, 2 C's, that is clofazimine and cycloserine, and then you have the bedaquiline, which is supposed to be given for 6 months only. So total you have 18 to 20 months of this all oral longer MDR XDR regime. So it's a all oral longer MDR XDR regime. Are we good with this? So will you remember these 4 regimes for me? Talking a little bit detail about this shorter MDR regime, which can be asked in your exam. The shorter MDR regime, you already know that we have the CHOBZEE, clofazimine. C stands for clofazimine, H for isoniazid, and it's in fact a high dose isoniazid. O stands for levofloxacin, B stands for bedaquiline, Z for pyrazinamide, E for ethambutol, E for ethionamide. So you are going to give 4 to, listen carefully, there is some confusions and some important points for you to remember for your exam. So you're going to give 4 to 6 months of CHOBZ regime. And then you're going to give 5 months of COZY regime, right? C stands for clofazimine, O is levoflox, Z pyrazinamide, E ethambutol. Now, for the first 4 months, we are going to give, so from start of the drug regime till 4 months, we are going to give all the 7 drugs, that is the CHOBZ regime. After 4 months, the intensive phase is supposed to be over. So for the 5th month, 5, 6, for the next 5 months. So after 4 months, you are going to give for next 5 months. So total is 9 months, right? So for the 5th month, 6 months, 7, 8 and 9 months. So for all these months, that is the 5th and 6th month, you are not going to give high dose isoniazid, and ethionamide is not to be given. Please note, it is not given. High dose isoniazid and ethionamide is not given in 5th, 6th, 7th, 8th and 9th month. It's only given for the first 4 months. Are we good with this? In the 7, 8, 9 months, in the last 3 months, the bedaquiline is also not given. Please note that bedaquiline is only supposed to be given only for 6 months. Please note, you should make a note that bedaquiline is only for 6 months. 6 months. Bedaquiline is only for 6 months. The indications for bedaquiline and contraindications I have discussed in Marrow edition 5, they all remain the same. The chances of cardiac arrhythmias, the QCT prolongation, the QTC prolongations, and cardiac diseases and pregnancy, they all are contraindications of bedaquiline. They are still the same. Bedaquiline has to be given only for 6 months, and high dose isoniazid and ethionamide only given for the first 4 months. Mind it. Now, in case, that's where the controversy comes. In case, I've written here the intensive phase has to be for 4 to 6 months, right? So now in case the intensive phase is prolonged, mark it carefully. In case the intensive phase, listen very slowly, very carefully. In case the intensive phase is prolonged till 6 months, then bedaquiline will be given for first 6 months, and high dose, in case it is prolonged, only in case it is prolonged, then high dose isoniazid and ethionamide will also be given till 6 months, and in the last 5 months, all 3 drugs will be stopped together. So in case there is extension of the intensive phase, all 3 drugs like bedaquiline and high dose isoniazid and ethionamide all will be given till 6 months, and after 6 months, if all 3 drugs will be stopped together. In case you are going for only 4 months, the intensive phase, in those cases for the first 4 months, all 7 drugs, and then in the last 5th and 6th month, last 2 drugs, that is the high dose isoniazid and ethionamide will be stopped, and bedaquiline after this 6 months will also be stopped. In case you are too much nerdy into the dosages, here are the list of dosages. Of course, I do not recommend you to remember the dosages, but in case you would like to remember, you can remember that this is the average standard dose from 46 to 45 to 70 kg person. The high dose isoniazid, ethambutol, pyrazinamide, levofloxacin, all the drugs that are written here, the dosages you can remember for your exam in case you want to. So please note, that is what you had learned about the rifampicin sensitive and the rifampicin resistant strain, and this is the 4 regimes or the 5 regimes that you need to remember for your exam. Will you do that? So now coming to the next point, That is a few points about the pregnancy and tuberculosis. If a female who is pregnant and she contracts TB or she gets TB, there are obviously two types of tuberculosis she might have got. Either it is a drug sensitive TB or a drug resistant TB in case of pregnancy. So obviously TB is an important issue in pregnancy. So in case it is a drug sensitive TB, we are going to give the DSTB regime. You remember 2 months of HRZD and 4 months of HRND. So that is the drug sensitive TB regime, and of course the female has to get MTP done, whatever the diagnosis is and whatever is the stage of pregnancy. According to that, we are going to give the regime. This is the same as you have done in the Marrow edition 5 module. Now the problem starts with the DRTB regime, and that is where the updates are. In case a female who is pregnant and has got MDR-TB or XDR-TB or a DRTB, so we asked about the duration of gestation or the period of gestation or the duration of pregnancy in case it is less than 20 weeks or more than 20 weeks. In case, mind it, please note that is where the changes are or the updates are. In case the drug resistant TB is the female is pregnant less than 20 weeks. In case the female is pregnant less than 20 weeks, we are going to advise MTP, common sense. And if the female takes MTP, the drugs that we are going to give is a shorter oral bedaquiline containing MDR RRTB regime. That is now the preferred regime. So please note that shorter oral bedaquiline containing regime can be given to female who is drug resistant TB and is eligible to receive the MDR RRTB. There is no fluoroquinolone resistance, there is no other resistance. So in those cases, we can start the shorter oral bedaquiline containing regime. Now in case, mind it, that's again an important up. So that's a 3-star update for you. Now, in case the female says that no, I cannot get MTP done, or if the duration of pregnancy is more than 20 weeks, mind it, already tuberculosis is an issue, and now on top of that, drug resistant TB, and on top of that, it is more than 20 weeks. So, if the female is more than 20 weeks, or if the female is unwilling to get MTP, so we are directly shifting the patient. I know MDR, bedaquiline is contraindicated in pregnancy. We have to advise the female. We have to talk to female, counsel the female for all the effects and adverse effects of bedaquiline. So in case the pregnant female is more than 20 weeks or she is unwilling to take MTP, she is supposed to be put on all oral, longer bedaquiline containing MDR XDR TB regime. So please note that depending on what her TB status, what the CBNAT, the FLLPA, the SLLPA and the DST report tells, she has to be put on bedaquiline or non-bedaquiline containing regime. So the preferred one are the bedaquiline containing regime. Of course, we all know that bedaquiline may have hindrance in pregnancy, may be teratogenic to the baby, to the fetus and to the mother also. But there have been some trials from South Africa which have shown that the level of teratogenicity that we earlier used to think is not as bad in pregnancy. So there are still more research to be done, but right now the guidelines are that in a drug-resistant TB, we have to give bedaquiline containing regime is the preferred regime if the female is eligible for that. So that was your update number 6. Update number 7. What about the WHO's BPAL regime? So BPAL regime means B, bedaquiline, BPAL regime. Bedaquiline, pretomanid and linezolid containing regime. So the BPAL regime, please note in the NTEP program, under our program, whatever drugs I have told you, DSTB, DRTB, H-mono polydrug regime, shorter MDR, bedaquiline containing, longer MDR, bedaquiline containing. These are the only 4 regimes that we offer. The BPAL regime is to be taken only under operational research. That is, only people or clinicians or the doctors who are more interested in research and the effects of BPAL regime, they can enroll themselves for the ongoing BPAL operational research under the NTEP program under the Government of India scheme. So they can take part under the operational research only if the patient has fluoroquine resistant and there is no prior exposure to bedaquiline or to linezolid. In only those cases, the patient may be eligible for the BPAL. So BPAL is essentially for people who are like pre-XDR or people who are eligible for BPAL and there is no exposure to bedaquiline or linezolid. So the dosage predominant is 200, bedaquiline 400 for first 2 weeks, and then it comes down to 200 and linezolid is 1200. So you can remember the dosage, but of course please remember BPAL is not a routinely used regime in the NTEP Government of India. Update number 8. Update number 8 is regarding the household contacts of tuberculosis. So the household contacts of TB can either be a DSTB or a DRTB. The DSTB, what is the drug that we used to give for all these cases who were like index cases, drug sensitive TB? So we are giving them isoniazid. You remember we used to give IPT prophylaxis, isoniazid preventive therapy, right? So we are giving them isoniazid preventive therapy to all the children who are less than 6 years. We're giving at the rate of 10 milligram per kg. That is regular isoniazid. Now, in case a patient is DRTB, the index case is DRTB. So now if the index case is DRTB, that is, you need to counsel and contact the screen the contact. If the patient is symptomatic, you have to see whether the patient is symptomatic or not. If the patient is symptomatic for TB, the contact is symptomatic for TB. So you do the investigation for TB. You find whether it is drug sensitive TB, drug resistant TB, first line LPA, second line LPA, and all that stuff you're going to do. Now, in case that patient is not symptomatic, so we are all talking about a patient who's the contact, the main index case is drug resistant TB and the contact is there. So if the contact is not symptomatic, if the patient is less than 5-year-old and the TPT, that is the TB preventive therapy, is not contraindicated, we are going to start the TPT. In case it is contraindicated, we are going to defer it. In case the child is more than 5 years old, we are going to test for IGRA, that is the immunogamma gamma release assay. So IGRA test has to be done, or the tuberculin sensitivity test has to be done. And if it is negative, only those cases we are going to start with the tuberculosis preventive therapy. So in these cases, what is the TPT which has to be started? So this has been updated. It could again be a 3-star MCQ for you. Earlier, we used to give pyridoxine and isoniazid in general to all patients. The index case could be drug sensitive or index case could be drug resistant. Now, for all the drug sensitive cases, we are still giving isoniazid and pyridoxine, but to drug resistant cases. So in case the patient, the index case was only rifampicin resistant. So what is that called? That is called as RRTB. So in case there is only rifampicin resistant. So in case there is only rifampicin resistance and fluoroquine is sensitive, to these cases, we are going to give fluoroquinolones, that is levofloxacin, 6 months. Please note, we are going to give 6 months of levofloxacin to all cases who are rifampicin resistant and they are fluoroquinolone sensitive. Please note, it has to be fluoroquinolone sensitive and rifampicin resistant. Now, in case there is rifampicin sensitive and only isoniazid resistance, in case there is only the isoniazid resistance, that is the H monopolydrug regime. So in case they are getting only the H monopolydrug regime, the contacts of these patients who are only isoniazid resistance, to these patients we are going to get this an important thing, and the Government of India had taken so much time to think whether to launch this on a public health basis, yes or no, but actually we have taken probably the courage to launch it. It is that all the contacts will receive 4 months of rifampicin. The contacts will receive 4 months of rifampicin, hoping that the rifampicin given in general to the contacts will not yield more rifampicin resistant cases. We just hope that it is on public health level. It should be safe, it should be workable, implementable, and it should be safe for the population. So please note that for your exam, you need to remember, if the patient, the index case, let us say this is the index case and this is the contact of that index case. The contact, if the index case is rifampicin resistant, you remember the other arm, right? If the patient is rifampicin resistant, in those cases, this patient is going to get levofloxacin, 6 months of levofloxacin if it was rifampicin resistant and there is no fluoroquinolone resistance, fluoroquinolone sensitive. In case this patient was rifampicin sensitive with only isoniazid resistance, in those cases, this patient, the contact is going to get what? 4 months of rifampicin. This can be asked in your exam. I am like, maybe this will be asked because a lot of work and a lot of discussions at the national level we had on this, whether to launch a 4-month rifampicin regime as prophylaxis for contacts of DRTB, yes or no. There was a lot of contemplation on that, and finally the government of India has taken a stand on that. Coming to the 9th update for you, the recent trials in MDR-TB management. You just know the names. You don't need to know the insights or the details of this. Just remember TB Champ. That's a testing strategy or a testing trial for levofloxacin. VQuin is again a trial which is for levofloxacin versus placebo, and Phoenix study is for Delamanid versus isoniazid. So just remember the names. That's what you need to remember about the recent trials in TB management. Coming to the next point, use of information technology in TB management. So in my main videos in Marrow edition 5, I've already talked to you about the 99 dots. You remember this 99 dots? First we had the NICSHE software. And then we had the 99 dots, which was a compliance system. So now we have, that was for the drug sensitive TB people. So now for the drug resistant type of people, for them we have the MERM containers, MERM containers. This is Medicine Event Reminder Management Systems, MERM. Medicine Event Reminder Management Systems. And these are containers which contain, I don't know if you can see it on the screen. It has a small chip inside this container. It's going to beep alarms. It is programmable. There is a USB device also attached to it. So it is programmable. It has the voice command. It has a visual, audio visual, both reminders are there. So the patients generally use it. It is a MERM for drug resistant tuberculosis. So coming to this slide, this is just a quick summary of what all things have happened in recent past. So since the launch of edition 5 videos, that is in the start of year 2021 to the end of year 2021, what all things have happened under the National TB program, I've just compared them. So talking about the edition 5 videos and the recent updates in the Delta video in this session. So talking about TB epidemiology, it's somewhat similar. Nothing grossly has changed. The only thing that is there is regarding the TB stats in India. There was the launch of the India TB report, which tells you about the notification of the TB cases. If you can, you should remember these numbers. Otherwise, that's okay. Just remember the total notified cases in India is 18.5. The total RRTB or the MDR caseload is in India is 9.1 per lakh population. Just remember these two numbers. You can remember that the proportion of people who were less than age 6 years who were initiated on TPT is only 1/3 population, that is 35%. That's all that you need to remember. So regarding the TB epidemiology, it's more or less the same. Coming to the definitions, I've already discussed with you definition. There was an update on definition, which we have already discussed regarding the launch of the pre-XDR definition. Diagnosis is still the same, that CBNAT is reinforced, nothing very special. The treatment regime, we have already discussed about the short oral bedaquiline containing regime, and the contacts of TB, I told you that the drug sensitive TB is still the same, but regarding the contacts of the drug resistant TB, we now have 6 months of levofloxacin or 4 months of pyrazinamide. The indicator, again, this was just a question which was asked just a few days back also on the social media, that what is the best indicator. Please note that ARTI, that is the annual risk of TB infection, is not an indicator which is used now. See, what happens over time is sometimes the MCQs which you see in your books or in your textbooks or even in some of the mobile applications, they actually lose their relevance over time. Because public health has changed, because the program has changed, because the guidelines have changed, the question loses its relevance. Earlier, it was said that ARTI is one of the good indicators to understand the impact of the tuberculosis or the burden of TB in a population. But now ARTI is no more taken because we are doing active case finding. So therefore, incidence of TB and notification of TB, this is one of the most important indicators, is notification of the TB cases. Regarding the organization and updates, there are a couple of updates we are going to discuss now. Integration of TB program with the health and wellness centers under the Ayushman is a major important update this year. See, what has happened is that you already know the structure. So this is your 12th update, which is with the health and wellness center. So you already know the triangle, right? You at the lowest level, you have the sub-centers, primary health centers, subdivisional hospital. These are the CHCs, that is the community health centers. Then you have district hospital, medical colleges. Simple. You already know this triangle. So talking about these sub-centers or the sub-health centers, the Ayushman Bharat, they launched the health and wellness centers. So along with the health and wellness centers and the primary health centers, at these centers, the program is going to offer diagnostic facilities, and we will also offer the treatment support centers. These are the dot centers. So please note, all the PHCs and the health and wellness centers, we will be doing sample collection for sputums, designated microscopy. At the CHC level, we will now have TrueNAT facility. At the district level, we already have the CBNAT. We are very soon going to launch the TrueNAT at all the district levels. At the medical college levels, we already have the liquid culture or the DST labs. So please note, CBNAT is available at almost all the major district hospitals. TrueNAT should be available at all the sub-district level or the sub-divisional hospitals or the CHCs or the FRUs. And then PHC and the sub-centers will be all designated microscopy center and the sample collection centers. So now this MCH program, the National Health Mission program, the Mother and Child Health program, the health and wellness centers, they are integrated with the NTEP or the National TB Elimination program. So this is what we have discussed, that the health and wellness centers and at the community level, the ASHAs, the Anganwadi workers, other volunteers, community leaders, community health officers, they will all do tuberculosis screening. They will promote tuberculosis awareness and all that at the community level. So talking about the secondary or the tertiary level, there is establishment of the DRTB centers at the medical colleges. In fact, under the National Medical Council bill, the NMC bill by the Indian Medical Council of India, they have said that the medical colleges, in order to get the further approval for running their courses, the MBBS courses or the MD courses, they need to have every medical college to have a DRTB center. So at the national or the district level, DRTBC committees, drug resistant tuberculosis centers are established. And then there is DT3C. So what is DT3C? Difficult to treat tuberculosis centers, difficult to treat tuberculosis centers, difficult to treat TB centers. So difficult to treat TB centers have been established along with the National Institute of Tuberculosis Respiratory Diseases, tuberculosis and respiratory disease. This is NITRD. This is in Delhi. So NITRD along with CTD, that is Central TB Division and the National Task Force. So the NTF with the CTD with the NITRD, they mixed together and made the collaboration for the DT3C, that is the difficult to treat tuberculosis centers. And we have at the medical colleges these things which are going on. So these are some of the updates. So around 12-13 updates are there for you to remember. And last is, of course, this is not an update. It's just a reinforcement that many students ask me, like, what are the incentives? Please note that any person who informs, it's the same that you have already discussed in the Marrow Edition 5 module. Any person who's informing for the TB patient will be given 500 rupees. That is for informing presumptive TB cases to the doctor, to the public health system. In case there is a private doctor, so whenever the patient is notified, they will get 500, and whenever the patient is reported the outcome, the doctor is reporting the patient's outcome, they will get another 500. So in regarding the treatment support incentive, it is massive support is being given 1,000 rupees. For the drug sensitive TB is given 1,000 rupees, and for the drug resistant TB we are giving, the government of India is giving 5,000 rupees. And transport, that's okay, you don't need to remember. The Nikshay Poshan Yojana, this was asked in your exam also. Nikshay Poshan Yojana, they are giving 500 rupees per month to the patient for improving their nutrition support. So these were 12-13 important updates that you need to remember in your exam. Next in line, the next program we are going to talk is NACO Program, National AIDS Control Program, updates from NACO Program. So first is just a reinforcement that these are the 4 types of investigations, 4 types of tests which are done for screening of HIV. So for screening of HIV, we are using enzyme immunoassay, immunochromatography, immunoconcentration method or the dot and blot method, and you have the particle agglutination method. So out of these 4 methods, any three out of 4 methods are to be employed for screening. Out of these 3, enzyme immunoassay has to be there. So in fact, you can say out of these 3, any 2. So enzyme, that is the ELISA based test, plus immunochromatography, immunoconcentration and particle agglutination, any 2 out of these 3 has to be done for screening. Coming to the updates which are there from the PARC 26th edition. So in PARC 26th edition, in fact, by the Government of India, by the Ministry of Health and Family Welfare and the NACP, National AIDS Control Program also, there is incorporation of dolutegravir into the ARV antiretroviral regime. So please note, earlier regime was tenofovir with lamivudine with efavirenz. So now this efavirenz regime is now taken as the alternate regime. So it is now taken as the alternate regime, and the preferred regime is tenofovir with lamivudine with dolutegravir for all adults. So we are giving this T, L and D. So we are giving this T, L and D, tenofovir, lamivudine, dolutegravir regime as a standard ART to all adults who are HIV positive. So we are supposed to start this antiretroviral therapy to all cases at any CD4 count, irrespective of the CD4 count. So for children, it is abacavir, lamivudine and dolutegravir, and for neonates, it is zidovudine with lamivudine with raltegravir, and in some centers, instead of raltegravir, we can also give the lopinavir ritonavir boosted combination. So that is an update for you from the PARC 26th edition regarding the ART module for HIV positive cases. Now in people who are with like maybe accidental exposure to HIV. So in case patient is accidentally needle stick injury or something happens to them, we are supposed to give the post-exposure prophylaxis. So the PEP has also been updated. Earlier it was tenofovir, lamivudine and efavirenz. Instead of TLE, we are again now giving T, L and D, tenofovir, lamivudine and dolutegravir as a single dose FTC tablet, which has to be started as early as within 2 hours preferably, but at least within the first 48 hours, and it has to be continued for 28 days. So it has to be started within 2 hours to be continued for 48 days to get the optimum outcome of this post-exposure prophylaxis with T, L and D for all adults and adolescents. For children, it is zidovudine with lamivudine with dolutegravir, and for children aged less than 6 years or weight less than 20 kg, zidovudine, lamivudine and lopinavir ritonavir instead of dolutegravir. So this is the updated PEP you have already done. Next is about the cotrimoxazole preventive therapy. Just to reinforce, please note that the cotrimoxazole preventive therapy is a double strength tablet. It is same what you have already done. So it is the double strength tablet. We are giving 800 milligrams of sulfamethoxazole with 160 milligrams of trimethoprim. So it has to be started. If the CD4 count is less than 350, it will be stopped with the CD4 count shows an increasing trend, with at least the threshold should be more than 350 on 2 occasions 6 months apart, with ascending trend of CD4 count and no WHO stage 3 or stage 4. Also, please note this is an update which was discussed in your Marrow edition 5 module also, because it was released in year 2019, that IPT has to be done for all children aged more than 1 year after ruling out TB. It has to be given with ART for all children living with HIV or the people living with HIV after ruling out TB. Please note that in case the TB is there and then you're giving isoniazid, you're promoting isoniazid resistance. So for all the cases of people with HIV, you're supposed to rule out TB and then we are supposed to give them isoniazid preventive therapy. So that's a similar update, but please note that this year in June, the government of India had released this letter, June 2021, the government of India had released this letter that dolutegravir based combination will also be used for the post-exposure prophylaxis. Again, another point for you to reinforce is regarding the HIV serosurveillance. In the HIV serosurveillance, there are three broad categories. You have the main high-risk groups, you have the general population, and the bridging people between the high-risk groups and the general population, these are called as the bridge population. So you have three groups: high-risk groups, population, and the bridge between them. The bridge is denoted by the male migrants. The bridge is denoted by the people who are long distance truckers. The general population, the proxy indicator is the pregnant female. So what does it actually mean? That if in case in pregnant female, the HIV prevalence is, let's say, 0.3%. So it technically, grossly, you can say that extrapolating this ANC female population, we can say that in the total general population in our country, the HIV prevalence is 0.3. If it is 0.3 in ANC. So general ANC is, or the pregnant female, they are the proxy indicators of the general population. High risk groups are four groups, that is the female sex workers, the male to male or male having sex with male, intravenous drug abusers, and the hijra or the transgender groups. So these are the high risk groups. The male migrants and the truckers, they are the bridge population, and the general is the ANC. So this is just to reinforce the points about the HIV serosurveillance groups which are there under the NACO program, Government of India. Coming to the next program, that is the National Leprosy Eradication Program. There is no new update. Only thing is that the paucibacillary and multibacillary, what is the treatment? So you already know that in India we already had updated this definition that pauci is any person who's with less than 5 or equal to 5 lesions, no nerve involvement, and the skin smear. This can be your MCQ. The skin slit smear should be negative on all the sites. That is pauci. Multi is any site if it shows positivity, or if there is more than one nerve, or there are more than 6 lesions. So please note that under the NLEP program, National Leprosy Eradication Program, please note that the pauci people, the people with paucibacillary, they will receive only 2 drugs. Please note that the paucibacillary will receive only 2 drugs. I'll repeat again, the paucibacillary will receive only 2 drugs, the rifampicin and dapsone. So paucibacillary will receive only 2 drugs and multibacillary will receive 3 drugs. This is under the National Leprosy Eradication Program. I know that as per the WHO program, either it is a paucibacillary or it is a multibacillary. They will receive 3 drugs: dapsone, clofazimine and rifampicin. This is as per the WHO regime. So I duly understand that WHO regime is there with 3 drugs for both pauci and multi. But under the Government of India system, we are still hanging on with the 2 drug regime for pauci and 3 drug regime for multi. Please also note that under the 2 drug regime for paucibacillary, I am talking about the paucibacillary leprosy, the multi-drug therapy for the paucibacillary leprosy, we are going to give dapsone and we are going to give rifampicin. Rifampicin is to be given only monthly tablet in the dose of 600 milligram. This is given as the monthly tablet, and the dapsone is given at the dose of 100 milligram. This is given as daily tablet. In case it is a child, for children aged less than 14 years, we again have MDT. So for rifampicin, it will be 450 milligrams for a child, and dapsone will come down to 50 milligram for a child. So please note that for a child age less than 14 years, it is a blue color blister for paucibacillary and a green color blister. For adult, we have a green color blister packet. So please note, rifampicin is to be given as monthly tablet and dapsone is to be given as daily tablet. 6 months for paucibacillary and 12 months for multibacillary. So this is given for 6 months. Coming to the multibacillary regime. In multibacillary regime, we are going to have 3 drugs. We are going to have 3 drugs: rifampicin plus dapsone plus clofazimine. So rifampicin is given in the same dose of 600, dapsone in the same dose of 100, and clofazimine is given as monthly dose of 300 and daily dose of 50 milligram. So 50 milligram you have the daily dose. In case it is a child, then rifampicin is given as 450 on monthly basis. Dapsone is given as 50 on daily basis. Clofazimine as 150 on daily basis. And please note that in case it is a child, the child will be given age less than 14 years, 10 to 14 years. Technically it is 10 to 14 years. So age 10 to 14 years, the child will be given clofazimine as 50 milligram only, but on alternate days. So they are given on alternate days 50 milligram clofazimine. So that is what can you see over here, these brown tablets, they are missing. Can you see these brown tablets? They are daily. So the brown tablets over here are daily on the adult side. You see, this is the adult side, and for child it is alternate day. So how I have remembered is, can you see that if I take a new page over here, can you see that we can either have paucibacillary or multibacillary? We can either have an adult or we can have a child. So for paucibacillary adult, you remember for adult it was a green color blister, and for child it was a blue color blister. You remember this? For paucibacillary, for adult multibacillary, it was kind of a pink or a red color blister, and for child it was a brown color blister. So how I have remembered is, child is for baby. So you have a B, brown, blue, baby. You remember that for child either it is blue or a brown. Blue will stand for common sense for pauci, and brown will stand for multi. And in adult it is green for common sense pauci and pink for common sense multi. So that's how you can remember these colors. But all said and done, please note that in multi-drug therapy for leprosy under NTEP is still the same. Just to reinforce this, that Sapna, this girl child is Sapna. Sapna is a school going girl child. So she's a mascot for leprosy, and Sapna is for promoting leprosy awareness in India.